Good morning, respected judges. The topic for my presentation today is Pediatric Penetrating Keratoplasty, Retrospective Study for Prospects in a Tertiary Care Center. Now, Waring and Lebson introduced the concept of pediatric keratoplasty in 1977. However, technical advances have lowered the age and increased the indication. Now, we need to keep a few points in mind while considering surgery in pediatric keratoplasty. These are: complete evaluation of corneal pathology is difficult, intraocular pressure measurement is difficult, graft rejection is difficult to detect and treat, challenges ensue in every step. Preoperatively, there are chances of deep amblyopia. Intraoperatively, there is low ocular rigidity with positive vitreous pressure, and postoperatively, difficult follow-up. Aims and objectives are: study aim to evaluate indications and outcome of the procedure and to analyze the visual outcome over a follow-up period of 12 months. Ma'am, 1 minute, the slides are running on their own actually. Slides are running on their own, I cannot continue. I need to go step by step. The slides are running on their own, at their own speed.
Can you give him the controls?
The slides are running on their own speed, so I cannot. I am giving the control manually.
Timer हटा दो.
Slides are running on their own, sir.
Timer हटा.
Shall I start from the beginning?
No, continue.
Good morning, respected panelists. The topic for my presentation today is Pediatric Penetrating Keratoplasty, Retrospective Study for...
Please start from where you had left.
Okay. This was a retrospective case review in 24 patients conducted over a period of 3 years. Data collection was done and systemic evaluation was conducted in consultation with a pediatrician. Examination under anesthesia was performed as and when required. Ocular evaluation included preoperative visual acuity, refraction, retinoscopy, visual evoked response, electroretinogram, and ultrasound B scan as and when necessary. Now, we excluded patients with regrafts, those with microcornea, patients with loss on follow-up. Those cases with intraoperative complications and medical records with incomplete data were also excluded from our study. The following chart shows the baseline characteristics of patients in our study. Preoperatively, patients were classified according to indications for surgery. These were congenital corneal opacities, acquired traumatic or acquired non-traumatic corneal opacities. The most common indication for surgery in our study was infectious keratitis. However, deteriorated visual acuity was the indication for grafting in eyes with keratoconus and corneal dystrophies. Most patients in our study, as shown, belong to the 11 to 17 years age group. The pie diagram shows here that the preoperative diagnosis prior to surgery. Visual acuity could be recorded in 83% of our cases, and optical correction and amblyopia therapy at an average of 3 weeks showed improvement in visual acuity in 63% of cases. However, vision more than 20/200 was achieved in only 25% or 6 eyes. The following diagram shows the postoperative complications depending on number, the average age group, the duration from surgery to complications, and percentage. The following chart shows the postoperative time interval of suture-related complications following surgery. Corneal allograft rejection was observed in 4 patients at an average age of 5 months. Final improvement in visual outcome in these young patients was seen, however, in only 1 case. We also aimed to plot a Kaplan-Meier survival curve to predict the survival of corneal graft, which showed association of vascularized cornea, intraocular inflammation, and simultaneous surgery with survival. The 2 patients in our surgery had raised intraocular pressure at the time of surgery. In all patients, however, one with Peters anomaly, the IOP was under control. The following chart shows postoperative allograft rejection in our cases. Now, coming to discussion, penetrating keratoplasty still remains a treatment of choice in poor resource settings. Smaller grafts and interacted single sutures may be beneficial. Graft rejection rates were found to be higher and earlier in the age group of less than 5 years. Congenital corneal opacities and combined procedures had high rejection rates in our study. Cases with combined concomitant procedures also had increased rejection rates. Our study suffered from certain limitations due to the retrospective natures of the analysis. Factors associated with poor prognosis, including treatment adherence, and a multivariate analysis could not be performed due to the small sample size. Future prospects include proliferation signal inhibitors, advanced definition techniques, and recent advances like cut and paste keratoplasty. The following are by references. I would like to conclude by saying the only thing worse than being blind is having sight but no vision. Thank you.
Okay, Dr. Subhajit, what were the common what was the size of your sample?
So size of the sample was 24 patients.
24 patients. All of them were in pediatric age group.
Where from starting from 6 months to 17 years. We considered the WHO definition and UNICEF came under 17 years age group.
What was the failure rate in these cases, overall failure rate?
So we have observed graft failure in our cases in 25% of our cases.
That
it is
means
considered a high-risk surgery, the young age group, but we observed in that...
The commonest indication where the failure was basically...
Infectious cases.
Infectious cases
Yes,
were
sir.
the least one.
Yes.
Okay.